Welcome to The Explainer. Today, we're diving into a group of medical emergencies that are so sudden, so severe, they can be fatal within just a few hours. They're called acute aortic syndromes. And you know what? Understanding them could actually save a life. So let's get right into it.
Okay, think about your body's entire circulatory system for a second. Right at the very center of it all is this massive, absolutely critical piece of infrastructure, the aorta. It's the main artery, the superhighway that carries all that oxygen-rich blood from your heart out to literally every other part of your body.
So what happens when that superhighway suddenly fails? We're not talking about a little pothole here. We're talking about a catastrophic multi-lane pileup. This is exactly where acute aortic syndromes come in. They're a whole group of sudden, life-threatening emergencies where the aorta fails in different but equally terrifying ways.
Now, to really get what's going wrong, we got to take a super quick look at how this vital artery is even built. Because it's not just some simple tube. It's actually a pretty sophisticated, layered structure.
The aortic wall has three distinct layers. You've got the intima, that's the smooth inner lining. Then there's the media, which is the strong, muscular middle layer, and finally the externa on the outside. Now, our source material humorously points out that for what we're talking about today, all the real action happens in those first two layers, so that's where we're going to focus.
So what exactly are these syndromes? Well, think of them as a family of three distinct conditions, and each one is a different way the aortic wall can fail. We're going to investigate these three culprits one by one: the penetrating ulcer, the aortic dissection, and the intramural hematoma.
First up, let's open the case file on the penetrating ulcer. Now, this one is less of a sudden explosion and more of a slow, grinding erosion that just suddenly becomes a massive emergency.
So the main thing to know here is a condition called atherosclerosis. That's basically the buildup of plaque or gunk in your arteries. In this case, a nasty plaque literally digs or ulcerates its way right through that inner intima layer. This creates a weak spot, which causes a bleed inside the aortic wall. You see this most often in older patients who also have high blood pressure.
And what causes that atherosclerosis in the first place? Well, our source material puts it pretty bluntly, blaming it on a lifestyle of delicious Burger King and tasty cigarettes. It's a very memorable way of saying that this particular aortic problem is deeply, deeply linked to our lifestyle choices.
Okay, so while the penetrating ulcer is a slow erosion, our next culprit is the exact opposite. It's a sudden, violent tear. It's the most common, and you could argue the most dramatic of the three, the aortic dissection.
And the numbers here are pretty stunning. Aortic dissections aren't just one of the syndromes. They are the dominant one, making up a massive 70% of all acute aortic syndrome cases. It's the big one.
I want you to imagine the aorta is like a high-pressure fire hose with an inner lining. A dissection is what happens when a tear forms in that lining. Super high-pressure blood then forces its way through that tear, literally splitting the layers of the aortic wall apart. This creates a dangerous second channel for blood, known as a false lumen, that runs right alongside the original true lumen.
And this slide just shows the result perfectly. On a CT scan, doctors can see these two separate channels, or lumens. As you can see, the original true lumen often gets compressed and becomes smaller, while the new false lumen is usually bigger, with slower, more turbulent blood flow. Doctors have a bunch of ways to tell them apart, but one really fascinating rule of thumb our source notes is that the false lumen usually ends up containing the left renal artery.
Now, there's a little bit of a medical chicken versus the egg debate here. Does high blood pressure just directly rip the inner lining, or does it first cause a small bleed inside the wall, which then bursts through the lining from the inside out?
But you know what? At the end of the day, as our source so elegantly puts it, from a practical standpoint, who cares? For the patient and for the surgeon facing this emergency, the result is exactly the same, a catastrophic failure of the aorta that needs immediate, life-saving attention.
All right, let's move on to our third and final culprit. This one is maybe the most mysterious of the group, the intramural hematoma. So if a dissection is a rip or a tear, I want you to think of an intramural hematoma, or an IMH, as a massive, contained bruise that happens inside the wall of the aorta. There's no tear into the main channel itself, but blood has collected between the layers, causing the wall to bulge out and get really weak. High blood pressure, again, is the main driver here. On a CT scan, it shows up as this really distinctive crescent shape of blood in the aortic wall. Now, the good news is that a lot of these actually heal on their own. The bad news, some of them can get worse and progress into a full-blown dissection, which basically makes them a ticking time bomb.
Okay, so we have our three culprits, the ulcer, the tear, and the bruise. But how on earth do doctors decide what to do in these high-stakes situations? Well, it turns out they use a brilliantly simple system. And get this, it applies to all three of these conditions. The treatment isn't about what it is, it's about where it is.
It's called the Stanford Classification, and it is the absolute key to making these rapid, life-or-death treatment decisions. It all just boils down to one simple question. Where is the problem located?
It's actually incredibly simple. The system just divides the aorta into two zones, based on how close it is to the heart. So if the problem, it doesn't matter if it's an ulcer, a dissection, or a hematoma, involves the ascending aorta, that's the part that comes right off the heart. It's a Stanford type A. If the problem starts after the major arteries branch off to your arms, in the descending aorta, it's a Stanford type B. And believe me, that A is the one you really have to worry about.
And this right here is the most critical takeaway of this whole thing. A Stanford type A is a surgical emergency, period. The risk of rupture is just so high that patients are rushed straight to the operating room. A type B, on the other hand, is usually managed medically with aggressive blood pressure control, unless other complications pop up. It's simple, but it's incredibly effective.
Okay, let's pull all of these threads together now and recap what we've learned about these really dangerous breakdowns on our body's main superhighway.
So we've met three pretty distinct characters in this story. We had the penetrating ulcer, which is a story of slow erosion from plaque, then the aortic dissection, a violent tear that's driven by high blood pressure, and finally, the intramural hematoma, a kind of hidden bruise that's also a consequence of chronic high blood pressure.
When you really boil it down, we've seen that the main villains behind these aortic failures are often atherosclerosis and hypertension, and both of those are conditions deeply linked to lifestyle. The story of the aorta isn't just about some catastrophic failure. It's about the thousands of small choices that help maintain that highway. Knowing what can cause the breakdown is the first step in preventing it. The real question is, what will you do with that knowledge?